Okay, we'll go ahead and get started. Welcome everyone to our afternoon session of the OCRA meeting. This is the Sexual Health After Cancer session. I'm joined by two of my very esteemed colleagues, so I'm going to start with introductions. My name's Dr. Kristin Rojas. I'm a breast cancer surgeon, but also a board-certified gynecologist. I run a program called Music at the Sylvester Comprehensive Cancer Center. Music stands for Menopause, Urogenital, Sexual Health, and Intimacy Clinic. It is a program dedicated to treating women with a history of any type of cancer experiencing sexual dysfunction. And I'm joined by two very amazing individuals. Speaking after me will be Dr. Teresa Neira, who's a board-certified sexologist. She's a diplomate of the American Board of Sexology and a licensed clinical social worker with over 20 years of experience. She worked in Mount Sinai Cancer Center, then at University of Miami with Andrea and I, and she's currently embarking on a new journey at Dana-Farber Harvard Cancer Center, where she'll be creating evidence-based programs to address the unique needs of the Latinx population. And then last but not least, Andrea Wood, who has been a pelvic health physical therapist for over 10 years. She is also a doctor of physical therapy. She's board certified in women's health through the American Physical Therapy Association, and she has a passion for treating a variety of pelvic health related disorders and is excited to talk about physical therapy today. So with that, one housekeeping item. If you'd like to ask us a question, we'll be doing answering questions at the end of the session, so feel free to place your questions into the chat. With that, I'll go ahead and get started. Okay, so my name's Dr. Kristin Rojas. Hold on, let me just minimize this one thing. And I work at University of Miami. If I mention any brands in this program, it's not because we receive any kind of financial incentive from them. All of the experience that I'm going to tell you about is from running our sexual health after cancer program. And so I feel like that's an important disclosure. So today I'm going to talk about menopausal symptoms with treatment, and then also vaginal dryness, painful sex, and low desire. My colleague Andrea Wood is going to be speaking a little bit more about the painful sex part, but we'll cover all those topics with a combination of our sessions. So many times when patients undergo treatment for cancer, specifically ovarian cancer or GYN-related cancer, especially if we're removing the ovaries and a patient has not gone through menopause, one of the first signs that you can feel is hot flashes. The hot flashes are essentially your brain telling you that you're going through estrogen withdrawal. Both of your ovaries normally release estrogen and that level of estrogen starts to decline slowly over time, and that's the natural process of menopause. However, when we surgically remove the ovaries or give a patient chemotherapy that quiets the ovaries, or we're giving a medication to hide their ovaries from chemotherapy, we can put someone abruptly into menopause. So we have some non-medication interventions for treating hot flashes. If any of you experience these, you've probably heard these before. We tell patients to make sure they're staying physically active, and I personally think it's helpful in the morning, anecdotally, dressing in layers so that you can always take a layer off, avoiding triggers such as spicy food, caffeine, and alcohol. Acupuncture, it can be a helpful intervention for many patients. It doesn't have as much research behind it, but there are really great investigators who are looking into that now and just recently received a lot of funding. So I think acupuncture is going to show that it works, and I know patients have said that acupuncture is really helpful. It can also be helpful for things like bone pain as well. And we have 3 non-hormonal medications that we can offer patients. One is venlafaxine, which is basically a type of low-dose antidepressant called an SNRI. There are other medications similar to venlafaxine that we can offer in this way as well. It's usually a much lower dose than what we offer a patient for antidepressant medication. A newer drug that we're using is oxybutynin, which is originally approved as a bladder medication. So patients with overactive bladder may benefit from oxybutynin because we can give it ends up treating both their hot flashes and overactive bladder. And then there's some other supplements on the market that have less evidence behind them, but some of the patients have told me about. One is Rolizin, which is a pollen extract from bona fide. But for many patients, especially if they get put into menopause before the age of 40, we know that estrogen deprivation over a long period of time can end up influencing and impacting your bone density, maybe even cognitive function. And newer data coming out shows that it may even increase your risk of things like heart attack. And so now in our space, we're really trying to focus on if patients may actually be eligible to get a little bit of hormone therapy back if we're removing their ovaries. It's not always a good option for every ovarian cancer patient. As you know, there's several different types of ovarian cancer. So the way we think about this, and when we're talking about hormones to help with hot flashes, what I'm talking about is a patch on the skin or a pill by the mouth. I'll talk a little bit more about vaginal estrogen in a moment. So for patients who have a tumor type that responds to estrogen, so this would be endometrioid type ovarian cancer, as well as other cancer types, we don't want you taking systemic hormones, which is hormones through the patch or the pill. But we can offer you those non-hormonal options that I talked about. For patients who have a cancer type that doesn't respond to estrogen, so this is actually serous ovarian cancer and the HPV-related cancers such as cervical cancer, vulvar and vaginal cancer, systemic hormone therapy replacement is actually oftentimes a good option for patients, especially if we put them into early menopause before the age of 40. So you want to check with your GYN oncologist about all of these options and make sure that this is right for you because there can be some nuances. There was even an article published a few years ago by one of our colleagues who laid out a pretty nice algorithm for treating patients with GYN cancer. And you can see here that high-grade serous ovarian cancer is supported by evidence with the use of hormone replacement therapy. So next, I'm going to talk about dryness and painful sex, which is the most common symptom that patients report when they present to our Sexual Health After Cancer program. We have an easy 4-step algorithm for this, and step 1 is eliminating irritants. So you'll see on my slides that I use the term GSM. GSM is the new term for vaginal atrophy. It stands for genitourinary syndrome of menopause. It includes dryness, painful sex, and urinary symptoms, and some of the other symptoms that my colleague Andrea Wood's going to talk about. When we see these patients, they oftentimes have an allergic reaction from using different products from, as you may know, in the supermarket, there's an entire aisle dedicated to many of these products. Some of them have artificial fragrances, which we can actually develop allergic reactions to. So the first thing that we do is have patients back off a lot of these products, including intravaginal soaps. So what I tell patients is the area outside the vagina or the vulva that is usually hair bearing, you can wash like the rest of your body. But the part of the vulva and the vagina that does not have hair, we don't want you using these soaps. Even if it says it's made for babies, it actually disrupts the vaginal microbiome and can start this cycle of infection, stinging, and burning. These ingredients that are very harmful are actually hiding in a lot of different products, including bath bombs, alcohol-based wipes, even detergents that you wash your underwear with. So we first have patients go through a list of all of those products and figure out if there's something that's potentially irritating them and causing them burning and stinging. Step 2 is moisturize. So vulvovaginal moisturization is actually different from lubrication. So moisturizers for maintenance. So just like you put your under eye cream on at night, you're going to think about doing this 3 times a week. And many patients are very significantly improved with non-hormonal moisturizers for the vulva and the vagina. So we want to apply this at least 3 times per week. I think it's best after showering. And for many patients, if you use single ingredient organic coconut oil, which is a natural antimicrobial, antifungal, this is an actual really good step, especially if you're experiencing burning and stinging, because it gives the delicate tissues of the vulva and the vagina time to heal before we add another product, such as a hyaluronic acid suppository. Many of you may know about the Bonafide hyaluronic acid suppositories, but there's actually some other cheaper hyaluronic acid products available on the market. And I can answer more questions about those at the end. We do want patients to avoid Vaseline or petroleum-based products. And for those who have UTIs after sexual activity, we can actually give you a single dose antibiotic to take after sex to prevent those bladder infections. So sometimes we do need to use vaginal hormones for patients who don't have a complete response from non-hormonal moisturizers. And this is specific for patients where they have the narrowing of the vagina with treatment. So they may notice that they have painful sex or that the vagina is shorter or narrower. And dilators with vaginal hormones can be really helpful. There's no evidence We typically do not use vaginal estrogen in patients with endometrioid type uterine or ovarian cancer, but no studies have shown an increased risk of cancer for all the other cancer types. And usually we only need to use vaginal estrogen for a short period of time where we can get patients back to painless sexual activity. We also have a cousin of testosterone called an androgen or DHEA, and that's FDA approved for painful sex. And we can sometimes also use a compounding pharmacy for vaginal testosterone. Now, this is hormones in the vagina, different from systemic hormones that I mentioned earlier, which is through a patch or a pill. Vaginal hormones are used to treat dryness and painful sex and other like recurrent urinary tract infections, but they're probably not going to help with hot flashes. Third step is lubricant. So every single time anything goes in the vagina, you want to think about using a lubricant because the less friction you have, the less pain. There's 3 different types: water-based, silicone-based, and oil-based, and different combinations of these types. We actually really prefer silicone-based lubricants for patients who aren't using condoms for STD or pregnancy protection. There's a really great hypoallergenic silicone-based lubricant called Uberlube that is really good for patients who have a lot of irritating reactions. Water-based lubricants are good if you're using a silicone toy or certain condoms. Uberlube is compatible with some types of condoms, but you always just want, if you're not sure, go to the website of the lubricant that you're using, and usually in the FAQs, it tells you if it's compatible with condoms or not. So what about libido? So this is a pretty difficult symptom to treat. First, we start by treating the pelvic floor muscle dysfunction, which my colleague is going to talk about. We also consider medication adjustments because antidepressants can actually make it impossible to achieve an orgasm. And so many patients are very distressed by this. And so Wellbutrin or bupropion may be a better option for those patients because it doesn't have sexual side effects. We also talk to patients about communication and relationship issues. I'm going to let my colleague go into that. We talk about sleep hygiene, so no screens in bed. And we also go through some audio erotica or other resources to get in the mood, including other apps. There's 2 FDA-approved hypoactive sexual desire medications that are FDA-approved for premenopausal patients. However, we're using flibanserin or Addy, the medication on the left, which is a once-a-day pill for many patients who are postmenopausal, and it is very effective in that patient population, although still thought to be off-label because it's not the same as the FDA approval. This is a serotonin modulator. It doesn't have hormones. We tell patients if you're going to have more than 2 alcoholic beverages that day to skip your pill because you're going to get sleepy and very tired. The other medication is more of a medication to get in the mood, and it's an injection you give yourself prior to sexual activity, and you can use it up to 8 times a month. It's a melanocortin modulator, which works in the brain, but the biggest side effect is nausea, which is not really sexy. So that's my summary of some of the most common symptoms. We have 2 free workshops from Sylvester, and I know my colleague is going to mention these also, available in English and Spanish. So feel free to take a screenshot of this, and then you can QR code and check out our free workshop.
Good afternoon, everyone. Thank you, Dr. Rojas, for that introduction, and I'll go ahead and get started. I have nothing to disclose. Hold on, I'm getting a screen situation here. Okay, so you see the screen. Let's talk about sex. Everybody sees it?
Yes, looks great.
Okay, great. Okay, so where do we start? With sex, it usually starts in the bedroom, but it really needs to start with communication. Most of us will learn the ins and outs about sex, no pun intended, but how many of us actually learn to communicate our needs and have open discussions about sex? These can be difficult conversations to have even before cancer. And now you have the added challenge of discussing these needs with an entire treatment team. That can be so overwhelming to the cancer patient that they can often not bring it up. And this is a missed opportunity to address and to often prevent sexual health issues. Sexual health often takes the back seat to fighting for your life. Patients may be focused on treatment, and sex may not be a current priority in their life, and then find themselves facing these issues once they are in survivorship. And some of these issues may be preventable. If we weren't talking openly about sex with our partners before cancer, it may feel like an unapproachable topic, sometimes worsening symptoms. For instance, a patient having vaginal dryness may be embarrassed to speak about it and continue to have sex without proper lubrication. This can lead to further damage to the otherwise delicate lining of the vagina, which can lead to painful sex, which can then lead to worst case scenario, vaginismus, which is the involuntary closing of the vagina, where it becomes practically impenetrable, to the best case scenario, just not wanting to have sex. The reason we have sex is because it feels good. So by not addressing these issues, we can actually exacerbate the situation. So if you only learn one thing through my part of this module, is to speak up. Speak up about your sexual needs, your satisfaction with both your partner and your team. Sex is ever changing, so you do have to remember to try not to replicate your previous life. Consider this more of an opportunity and acknowledge the challenges. So how many of us actually live sexually fulfilling lives? How many of you started this cancer journey with an amazing sex life? For some, it may be the case, but through my years as a sex therapist, most people were not enjoying their full sexual potential before sex. A lot of it having to do with the last slide, not knowing how to communicate our needs to a partner, not knowing our own bodies, or not being in tune with our sexual health and with our sexual self. Cancer, with all that it takes from you, can also be an opportunity to take things back. The reality is that our sexual life is ever changing, whether it's pregnancy, kids, your career, weight gain or weight loss, hormonal changes due to aging or other factors. So many factors besides cancer can affect our sex life. The secret to a fulfilling one is being open to that change and getting creative in every step of the way through all of life's journeys, twists, and challenges. When communication, intimacy, and pleasure are the focus, we can overcome most of these challenges. The goal should not be to replicate what you have, but to work with what you've got. It's all about redefining. So some of the factors influencing sexual function, and I'm preaching to the choir here. What can I say? Cancer is not sexy. From the invasive surgery, some directly on the sexual organs, the breast, the colon, to the side effects of chemo and radiation, the physical changes in the body, as well as the psychological factors of all of these losses, which can lead to anxiety, depression, and sexual disorders. Cancer is the anti-aphrodisiac, and it is often after the cure comes that comes the sexual challenges, right? When the patient is ready to enjoy the life they worked so hard to save. And now they're faced with the sexual issues caused by cancer, its treatments, and its many losses. It's not a surprise then that the arousal may take more time now. It's normal and common for cancer patients to experience vaginal dryness, as Dr. Rojas explained, irritation, pain. And these symptoms can develop into vaginismus, low libido, and difficulty with orgasm. Patients may experience a change in erogenous zones, such as a woman who loses her nipples due to a mastectomy and finds that they were an integral part of arousal or orgasm. They may need to go back to the drawing board and explore other areas or ways to experience pleasure. When you're faced with all of these issues, it can lead, of course, to psychological issues, mental health issues. Cancer can rob you of your sensuality, your self-esteem, even your identity, and of course lead to all of these issues that you see here, to only further exacerbate the situation and lead you to withdrawal and not wanting to speak about it. Gynecology oncology patients often have to overcome the hardest challenges, as their cancer can directly impact the vulva, the vagina, and reproductive organs. The surgeries can be quite invasive, often removing all parts of those organs. These patients are especially vulnerable to vaginal thinning, dryness, problems with elasticity, vaginal atrophy, and of course, pain. It really takes a multidisciplinary approach to deal with some of these issues. This presentation, we have Dr. Rojas, we have Andrea Woods, and myself. And it's three people addressing different parts of sexuality. And this is really the team approach that should be taken with every patient, because it's not only about learning about moisturizers and dilators and your pelvic health, learning also psychologically about how to deal with your body image issues, how to deal with intimacy issues, communication. All of it will be helpful to you in navigating through your sexual health post a cancer diagnosis. Radiation to these organs can cause incontinence, irritation, burning, and of course lead to pain and low libido. Gynecology oncology survivors that didn't address some of these issues during treatment in ways that could lessen these symptoms will often have fibrosis or vaginal stenosis, which is when scar tissue begins to form in the vagina. Scarring causes the vagina to become narrower and shorter, making penetration sometimes difficult or impossible. And chemo can also worsen stenosis. So it wreaks havoc on your sexual organs and your sexual health. I want to go into ostomy pouch sexual considerations. Patients with ostomy bags will ask, will I ever have a fulfilling sex life after ostomy surgery? It's a huge concern. And the answer is yes. There is definitely a period of adjustment after surgery, and some ostomies can affect intimate relationships more than others. But as mentioned earlier, communication is a key factor in reestablishing sexual expression and intimacy. Ostomy surgery may present more concerns for single people. When patients choose to disclose, may depend on the type of stoma they have and the relationship they have with the other person. They may want to empty the pouch beforehand, even if not full, and be mindful of their consumption before sex. An ostomy bag can make patients feel anxious and self-conscious. It's likely that their partner will be anxious about sex too, and may be afraid of hurting their stoma or dislodging the equipment. Patients should be encouraged to talk to their partner about the fact that sex is not likely to harm the stoma. For people with abdominal ostomy, sexual function may or may not change. Women could sometimes have pain during sex. These problems usually do get better with time. Patients need to explore different positions if the pouch or stoma is in the way. They can also purchase ostomy deodorant spray to eliminate odors. The type of intimate clothing that is worn may have to change. For example, women may consider wearing open panties, teddies, a short slip or nightie. Patients can also purchase pouch covers. Finding a local or online support group may help patients normalize their experience and find support from others. I find that developing a system of support, my patients have been able to navigate having ostomy pouches and some of the other losses that cancer brings along with it. So whether it's body image issues, low libido, anorgasmia, vaginal dryness, painful sex, vaginismus, vaginal stenosis, or other health issues, there are interventions you can do before, during, and after treatment that will prevent, eliminate sexual health issues. The first one being communication with a capital C. Sex therapy, online counseling, and education will help with this. Learning to voice your concerns, adapting behavioral changes, developing short and long-term goals, and working with a therapist to reconnect first with your body and second with your partner, if you have one. Most important thing of sexual health is being in tune with yourself to allow yourself to feel pleasure again. This is sometimes difficult as you're navigating through cancer treatments or cancer survivorship. Dr. Rojas talked a little bit about vaginal moisturizers and lubricants for penetrative sex. Andrea Woods will be talking about vaginal dilators to prevent vaginal stenosis caused by radiation and exacerbated by chemo. Also prescriptions, medications that may help, as well as working with someone like Andrea, a pelvic floor therapist, for rehabilitation of the pelvic floor. One of the biggest losses experienced by cancer patients is the loss of their former self, that feeling that you don't really know yourself post-cancer. For some patients, this is the first time they are faced with their own mortality. Preserving your sexual health may take a back seat to that. Patients will get lost in the fight and often lose this part of themselves in the process. The key is to find that person again. No one goes through cancer treatment and comes out the other side unchanged, but being able to consolidate those losses and work with what is left creates a unique opportunity for growth and to redefine yourself. So how do you do that? How do you feel sexy again? Well, you can start by looking at yourself with kind eyes. You can start by redefining beauty. Get comfortable with your new image. Learn to view your body for what it has done for you. Focus on the parts that you find beautiful and work with areas that you don't. Be kind to yourself. We are our worst critics. Normalize all sorts of bodies. Work on your appearance and mental health by adding exercise to your daily routine. Reconnect to your body through touch and massage. Figure out what your sexual triggers are and make sure you expose yourself to them. Dr. Rojas talked about listening to erotica. You may read, you may, find out what is stimulating to you, whether it's visual, auditory, and focus on that. Combat negative thoughts and replace them with more realistic, positive ones, and learn to communicate. Again, the word communication keeps coming up because that's the most important part, starting that conversation. Some patients may need to work with a mental health provider to work on these issues and techniques to address body image issues or other psychological problems caused by cancer treatment, including intimacy issues. Sex therapy or online sexual health counseling. Patients looking for an ASEX certified sex therapist anywhere in the US can go to the American Association of Sexuality Educators, Counselors, and Therapists website. Here in Florida, we also have the Center for Marital and Sexual Health of South Florida. They are located in West Palm Beach, but do offer telehealth appointments. They have experience treating cancer and cancer-related sexual problems. International patients can be referred to the American Board of Sexology website, which covers sexology professionals in 26 countries, including board-certified diplomats. And I always mention Leslie Shover, who is a clinical psychologist internationally recognized as an expert on sexual problems related to cancer. She spent many years on the faculty of MD Anderson Cancer Center and the Cleveland Clinic. She is now offering telehealth private practice and can treat individuals and couples in 27 states. Online educational resources to learn more about these topics discussed. After Cancer Solutions for Sexual Health Resources for Men, Women, and AYA. Here's a full list of different websites that you can go to. The Scientific Network on Female Sexual Health and Cancer is a global interdisciplinary network of clinicians, researchers, and healthcare professionals who work to promote sexual well-being in women and girls affected by cancer by advancing evidence-based education and practice. And they have on their website webinars and a yearly conference for providers as well as resources for patients. And of course, the Ovarian Cancer Research Alliance with programs like these. There are a lot of great resources online to provide to patients. At Sylvester Comprehensive Treatment Center, the YouTube channel, we have multidisciplinary sexual health workshops in both English and in Spanish, led by Dr. Kristin Rojas. You can find these workshops online for comprehensive sexual health information, and both Andrea Woods and myself are joined along with Dr. Rojas in those multidisciplinary workshops about sexual health. So in conclusion, a cancer diagnosis will alter your life in many ways, including your sex life. You can take charge of your sexual health by learning to communicate with your partner and your team using the interventions, resources, and referrals available to you, and start early. Don't wait until the problems develop. Take a proactive approach to your sexual health. And if you are already in survivorship, then seek help and guidance to work on these issues, keeping you from having a more fulfilling sex life. For any questions about this workshop, feel free to email me, or you can follow me on social media. I will be available to answer questions. I will reply to any email that I receive. Unfortunately, I do need to take a flight when I'm done with this presentation, so I'll be coming, signing off, but you can reach me for any further questions at any of these social media or email me. Thank you so much for your time.
Hello, everyone. My name is Andrea Wood, and as Dr. Rojas nicely introduced me, I am a pelvic health physical therapist at the University of Miami. I am so excited to talk to you about physical therapy's role in improving your sexual wellness during the ovarian cancer continuum. And the first question that I find that a lot of individuals have is, what is pelvic health physical therapy? A lot of people don't even realize that we exist. And there is an entire section through many physical therapy associations, including the American Physical Therapy Association and the World Physiotherapy, with specialized training beyond their physical therapy degrees. So what we do is we treat and optimize the function of the pelvic floor muscles and surrounding musculature, and we help treat men, women, non-binary, and children with a variety of pelvic health disorders as part of an overall medical team. What our focus is to help restore the quality of life in individuals with or post a variety of cancer diagnosis, including but not limited to breast, prostate, ovarian, cervical, and colon cancer. And we help with not just during your cancer diagnosis, but with the effects after the cancer diagnosis and the cure as well. So what conditions do we treat? What are types of conditions that you might experience as a side effect of your cancer treatment? And things that we help with include incontinence of pee and or poop. We help with urinary urgency. So that is that feeling of, I gotta go to the bathroom constantly. That can sometimes be a side effect of atrophy of the pelvic floor muscles and radiation. We also help with overactive bladder symptoms as well. So again, that constant feeling of needing to go. We help with painful intimate relations and painful intercourse. We help with pelvic pain that might be also interfering with intimate relations. Constipation is another common thing that we help with, and I find often that constipation can interfere with intimate relations. We help with vaginal atrophy and stenosis, so we work on things like stretching of the pelvic floor muscles, and then when appropriate, helping to work on the coordination of the pelvic floor muscles again, and a little bit of strengthening to help get better blood flow and health of that tissue. And another big important component of your intimate life and also your pelvic floor function is keeping you healthy through the promotion of good pelvic habits and also helping with exercise throughout the lifespan. One of the things that we know, for example, is urinary incontinence is a big limiting factor in physical activity for many women. So getting you active through helping with your pelvic health symptoms also will have indirect effects too, as well as on your overall sexual wellness. Before we go on, before we talk and get a little more into sexual wellness, I want to clarify that when I'm referring to sexual wellness, I'm not always implying intercourse involving penetration. Sexual wellness, I definitely feel like extends beyond just penetration, and intimate relations helps with a relation of a sense of self-esteem and well-being, as Dr. Neira has also pointed out. And so when I refer to sexual wellness, we're also helping treat individuals who might have pain potentially with outer course or any type of pain with masturbation. So when you're seeing a pelvic health physical therapist for any type of issue with your intimate relations, we aren't always just focusing on penetrative intercourse. So the first thing that I like to educate my patients on are, what are the pelvic floor muscles? Because a lot of individuals don't even realize that they have different muscles within the pelvic floor. And the pelvic floor muscles are actually 3 layers of muscles within your body. And they have to contract well, but they also have to relax well. So a lot of people, when they think of pelvic floor muscle function, they think of what we commonly know as Kegels, but it's also really important that you're able to lengthen and relax the pelvic floor, especially when you're having pain with intimate relations. The pelvic floor muscles, they attach all the way from the pubic bone to the tailbone to your hip bones. So any dysfunction with them can cause a lot of radiation of symptoms to various areas, including tailbone pain, suprapubic pain, hip pain, and low back pain. And the pelvic floor muscles serve for a lot of functions. And I tell a lot of my patients to remember the 5 S's. So the first one is support. They help support your pelvic organs, such as your uterus, bladder, and rectum, kind of like a hammock underneath your organs to help keep them in their right place. They serve for sexual function, which helps with orgasm during intimate relations. Pelvic floor muscle dysfunction can cause a lot of pain with intimate relations. So, for example, with arousal, if you can't get good blood flow in, that can cause difficulty with arousal, and also post-orgasm. If you're having a lot of issues with your pelvic floor muscles, especially tightness, that might lead to pain post-orgasm post having an orgasm. Some pump, they help move lymph and blood. They're part of your lymph and blood system and help move fluid up and down your body. So sometimes when there's issues with the pelvic floor muscles, that can lead to increased swelling in the labial and the perineal area, and then that can also interfere with intimate relations. Sphincteric, they help us control pee and poop and help push poop out. And stability, they help stabilize our hips and back and pelvis as part of our overall musculoskeletal system. So one of the things I like to say to my patients is hips, core, functional pelvic floor keeps you out my door. So they all have a symbiotic relationship around the pelvis. So pelvic floor muscles do play a large role in our ability with arousal and orgasm as well. So during an orgasm that often occurs with the peak of sexual pleasure, the pelvic floor muscles are going to contract rhythmically. Pelvic floor muscle dysfunction can definitely interfere with that orgasm by the issue of if you have weak muscles, that can cause poor orgasm due to decreased contraction. However, what you also may have is too tight of muscles, which can restrict blood flow associated with arousal and create pain during and after orgasm. Muscle tightness can also interfere with many of the nerves that also run through the pelvic floor muscles, which can cause an altered sensation and sometimes pain with orgasm too. Often what I see is that the pelvic floor muscles can be both tight and weak, which can create a damper on your satisfaction with orgasm, because also a tight muscle is not a strong muscle. Chronic tightness can lead to also pelvic floor muscle weakness. But the good news is finding a pelvic health physical therapy in your area can help conservatively optimize your pelvic floor muscle function and help with these issues. So there are different things involving a cancer diagnosis that may affect your pelvic floor muscles and sexual wellness. And a lot of these things Dr. Rojas already talked about and touched on. However, one of the big things too that we help with generally with pelvic health physical therapy is vaginal stenosis post-radiation. And so that is something that can be a common side effect. And also sometimes we see altered colon motility post-radiation, which can damper your sexual wellness. So working on just your GI issues and getting you to empty your bowels better can also help too as well. The biggest thing that I want to touch on that has not been gone over in this presentation is also we help promote joyful movement for you, because that's important for your overall well-being and fitness, which can help reduce pelvic floor muscle atrophy and in turn then help improve your sexual wellness. So physical therapy can help offset a lot of these issues that you may have associated with any type of reproductive cancer diagnosis. And so that it is very important to try and find a pelvic health physical therapist. When you come to us, what you can expect on your first visit is an active listener about your cancer journey who wants to know your goals, education about pelvic health and good habits to incorporate into your day, such as toilet posture, pooping techniques, frequency of bathroom visits, and proper hydration and exercise. Doing a detailed external pelvic assessment and internal pelvic floor muscle assessment if you're comfortable with it. You're always in control of the session with us, so doing an internal pelvic floor muscle assessment is not always required on the first session. We initiate a tailored exercise program throughout the course of treatment to give you autonomy in your care, and we help with instructions of techniques on conservative ways to help manage your pain independently for increased quality of life. So we're going to touch on a couple techniques for better intimate relations, but one of the common things that we help with is dilator training with pelvic health rehabilitation. And there are many different kinds of dilators that you may choose. So there's different dilators that are silicone based, there's plastic dilators. And one of the things that we help with is teaching you how to use them. So sometimes I may just start a patient with the smallest dilator and have them practice putting it on their inner thigh muscles as they're working on calming breathing techniques and thinking about letting go of a little bit of gas or a little bit of urine in their head, just to get them used to relaxing their pelvic floor. It's not necessarily that you're going to let go of some gas or pee. It's just giving you an image to try and help cue that relaxation within the pelvic floor muscle region. Another example, I may tell a patient if they're just using the dilator first on their inner thigh as they get closer to the opening, is I might say to them, okay, I want you to think about relaxing your glutes and taking a nice deep breath in and out. And again, all these types of images may help with pelvic floor muscle relaxation. Then patients will work on inserting different sides of the dilators when they feel comfortable. I tell my patients I don't want dilators to create more than a 3 out of 10 discomfort, because then that's going to reinforce that pain cycle response, which we don't want. So what we have is patients work slowly with different size dilators, and we help with working on ways for them to insert them that are comfortable to help kind of progress them to where they want to be. Pelvic wands are another option too as well, which is all the way in my upper right hand screen. Those can sometimes be used too for some more advanced stretching of the pelvic floor muscles as well. And I always suggest that you see a pelvic health PT to learn how to use one. Intimate relations prep, one of the things you're going to see included in this presentation that I said OCRA was some pelvic stretches that you can try before you have intimate relations. So examples include like the happy baby pose, a butterfly pose, and I always recommend only do these stretches if they don't cause pain, but there are ways that can help indirectly stretch your pelvic floor muscles before intercourse. Working on some diaphragmatic breathing before intercourse, which is also included on your handout, can really help, especially too if you have pain with penetration. There are movement connections between the diaphragm and the pelvic floor, so taking a nice slow inhale with insertion can sometimes help with pain with insertion. We talked about lubrication with Dr. Rojas. Sometimes what I'll have my patients do is use an oral syringe and insert the lubricant internally to help get a little bit more lubricated versus just putting it on their partner. And like we said, uses of dilators or a pelvic wand prior to intercourse. This is another great product, which again, also too, for a financial disclosure, I do not get any financial benefit from suggesting these types of products. These are just products that have really helped my patients. The ONIT is a great thing to take a look at. If you're having pain with penetrative intercourse, the ONIT can be a great thing. It's a 3-ring stackable system that you can place on your partner and then control the depth of penetration. So if you are having a lot of pain with penetration right off the bat and you want to work on less depth of penetration, you can utilize the ONIT, and as you get more comfortable, you actually remove one of the rings. And so that helps you to control the depth of penetration, and it can be a great way and a great form too of a little bit of cognitive behavioral therapy to get used to penetration in a way that feels safe and secure for you. And then there's also positioning considerations. So these are all types of positioning considerations to try, given what you maybe experience. So these are examples that you could try and utilize. Examples might include, if you're having low back pain, putting a pillow under your stomach may help, and keeping that low back in a neutral position. Having any history of pelvic surgery or reproductive organ removal, again, considering using an ONIT might help, or sitting supported on a chair facing front. These are all ideas that you can utilize. Another common one is if you're having hip pain, sometimes being in that quadruped position or also on a stomach with the pillow under the abdomen can be a common thing that can help patients. And then having any upper extremity pain too as well. You can also utilize over a pillow under the abdomen, or working more balanced onto your forearm supported on a sofa. So these are all examples of positions that you can try. And we help with a lot of the additional issues, like I said, interfering with your sex life. So if you're leaking during sex or having any loss of poop beyond your control during sex, we can help with that. Constipation that might cause discomfort with sex, we have a lot of techniques that we can help with that. Any nighttime peeing that prevents you from getting your Zen sleep that contributes to fatigue will impact your sex life, and that is something that we can address. Low back pain, abdominal pain, any type of pelvic girdle pain or hip pain is something that pelvic health PTs are also helpful with addressing. And then also working with any type of balance issues and fear of falling or cancer-related fatigue. So how do you find one of us? These are ways that you can find one of us. There's the International Organization of Physiotherapists in Pelvic and Women's Health. There's also the Physical Therapist Locator through the American Physical Therapy Association on pelvic health. There's the Global Pelvic Health Alliance and the Herman and Wallace Practitioner Directory. So these are all directories that you can take a look at to try and find a pelvic health physical therapist near you. Thank you so much for all of your time.
Thank you so much, Dr. Rojas, Dr. Neira, Dr. Wood. This is so informative. Really, really important information shared in a very honest and clear and transparent and open way. And please, everyone, as wonderful as our presenters have been, you feel free to ask questions. This is the time. I want to thank Dr. Rojas for also putting in the YouTube channel for the sessions that they are offering on YouTube. Watch them, participate in them. They are wonderful, informative, and really exactly a great way to learn and get this information right from the comfort of your own home.
I have a question for my colleague, Andrea.
Sure.
So I didn't get into this during my discussion, but there are, I oftentimes have patients come in who are, read different things online about different devices or for sexual function, or different treatments. Like one thing I often tell patients when they're asking me about these like yoni steams or V steams is like, stay away from those. Those are not helpful. Your vagina does not need steam. It's not going to, it's not, it, and I've actually seen patients who are burned. I also have patients who are recommended to have the Mona Lisa laser or some sort of intravaginal laser treatment. And I strongly advise against having that treatment for patients with a history of cancer, because we take care of a lot of women who are harmed by those. One thing that patients also talk to me about that's in your wheelhouse is these like weights you can place in your vagina or these devices that hook up to your phone. And me personally, I'm always trying to teach patients how to relax those muscles. So I feel like wearing something like that is not a good idea. Can you tell me how you counsel your patients on that?
Yeah, so one of the things that you see is the rise in a lot of women's health digital health companies and also a lot of women's health related products. And while I think there's a lot of advantages of these products, one of the things I really advise my patients is they don't replace actually seeing a specialist to make sure that you're appropriate for that product. So vaginal weights can be helpful for the right person. But generally, what we see with an ovarian cancer diagnosis, especially with a lot of the treatments that are associated with it, is not necessarily a strength issue that needs to be addressed right away, but rather there's a tightness issue. So what I compare that to my patients is if I kept my bicep tense the whole day because it was tight, and then something tried to touch it or penetrate it, it's going to feel tight, it's going to feel sore. So for example, when you use some of the vaginal weights or some of these apps where you put a sensor in, you hook it up to your phone and it's telling you to do a bunch of contractions, what you're doing is you're basically perpetuating that same tightness that's causing you with the pain with intercourse. So it's really important that for a lot of these patients that we work on down training first, where we're working on lengthening, stretching, getting those relaxation techniques in first. And then once they learn that proper coordination, if they are appropriate, to do a little bit of strengthening. And I really recommend that under the guidance of a physical therapist to help just get some better blood flow and strengthening back into that tissue to help with the atrophy. That can help too a little bit. The other quick thing I want to say is I always advise my patients, any program that's going to be telling you to do 50 plus Kegels a day and things like that, it's not functional. You wouldn't go do 50 plus bicep curls a day. So you want to make sure that you're also getting the right dose of what you need. And that's why it's really important to connect with a doctor or a specialist in this area to make sure that you're actually doing something that's suited for your body.
Thank you. We did have some questions in the chat. If you don't mind, the first one, I'm starting to see a pelvic floor therapist soon. What can I expect from my first visit? Any tips on what to ask them?
And so seeing your pelvic health physical therapist on your first visit, it can feel a little intimidating. And so a common misconception is that on the first visit, I have to do an internal pelvic floor muscle assessment. That generally involves where a patient undresses from the waist down, and using a lubricated glove finger, we assess certain aspects of your pelvic floor like tightness, pain, strength, endurance, and power. That does not have to always happen on the first session. So a lot of pelvic health physical therapists, we're trained to always ask for your consent in what we're doing. And we don't want to reinforce fear on you. So one of the things, if you are apprehensive about a pelvic health physical therapist initial therapy initial evaluation, when you go in, just let the physical therapist know. And then ask the physical therapist, hey, can you explain to me exactly what we're going to do and why we're doing it? Asking why you're doing something is not something to be ashamed of, because it's your body and you want to understand why you're doing what you're doing during treatment and evaluation. And so great questions to ask are also, if someone is explaining what they think is going on with your pelvic floor muscles, if you don't understand how they're explaining it, just say to the provider, hey, do you mind explaining this in a different way? Because I'm having trouble understanding. Or perhaps you're a visual learner, so you might say, hey, do you have any models or anatomy models, which a lot of us generally have? Can you maybe point to what you're referring to and explain it in a little bit of different terms? So don't be nervous to start forming that team relationship with your physical therapist and asking a lot of questions, because a lot of times, more than not, they might not realize that you might not fully understand something, but a lot of us are very open to listening and wanting you to understand exactly what's going on with your body. Because if you know what's going on, then you're going to be able to empower yourself more and help yourself more.
Can I
Thank
answer
you.
the question about menopause before 40?
Sure.
Yes. So there's a patient someone wrote in about menopause before 40 and not being able to take hormones. There's a lot of misconceptions about who can take hormones. So I would first ask your providers for clarification on why you cannot receive hormones, because many providers are quick to say, oh, no, you can't. But actually, there's pretty good data showing the safety and many ovarian cancer survivors. Okay. So that's the first thing, because menopause before age 40 will, meaning your estrogen is very low, can have really significant long-term effects when you go through menopause that early, like bone density, potentially an increased risk of dementia, heart attack, et cetera. Like, we're just now learning the effects of what happens when we remove the ovaries of BRCA1 patients when they're in their mid-30s, okay? Because that's a recommendation that just happened in the last 20 years. So we're just now learning the long-term effects of what that means. So I think the first step is to make sure you actually really can take hormones. And there's all different kinds. There's by the mouth, there's patch, there's vaginal. So double check with your provider. And I would encourage you to ask multiple providers why you were told you can't use hormones, okay? The second thing, when do hot flashes go away? Usually hot flashes are like the only thing we've talked about that actually gets better with time, even if you maybe don't do anything about it. But everyone is different. I doubt you're going to be having hot flashes for 20 years. Usually your body, I would say most patients feel a little better after a couple of years, but everyone is different, okay? So talk to your doctor about best treatments for how to manage hot flashes, because especially if they're disrupting your sleep, you can't tackle all the stuff you need to tackle the next day if you're not sleeping well. So please make sure you're talking to, and if one doctor doesn't really have a lot of solutions for you, ask another doctor, ask your primary care doctor, ask your gynecologist, ask your psychiatrist, ask your psychologist, find another primary care doctor. You know, we really are working to have more resources for patients like you, and just saying, oh, I don't know, or there's not an option isn't really appropriate anymore.
Dr. Rojas, I mean, on that line of finding someone to talk to, someone you can trust, Krista posted a question, and I think it's something we hear on a regular basis, which is, why did my gynoc not warn me? Who do I talk to? She has more of a message in there, but it really does come down to, how do you know who to talk to if your team is not bringing it up?
Yes, I tell patients, bring up these symptoms every single visit, because your providers, like, there's so much that people are learning, and your oncologist is probably very well intentioned, but we just started talking about these issues like in the last 10 years. And so a lot of what I do is also provider education, but many people are still trying to get their resources together to offer patients and are kind of intimidated by the topic. But you've already gone through cancer treatment. You have nothing to lose. Like, bring it up with every single doctor, because if your oncologist or provider has 5 patients tell them, hey, ever since you took my ovaries out, it hurts when I have sex and I'm having vaginal dryness. Like, if 5 patients say it that day, they're going to go home and put the resources together for you. So ask every provider and ask at every visit, why they didn't bring it up, especially in the context of like complex history is, you know, I can't really answer for that, but I think people are doing the best they can. And I'm so grateful for OCRA for allowing us to talk about these taboo topics. I think OCRA and other organizations are really taking a stand and putting this out there. And so, and I mean, if you think about it, menopause was a dirty word 5 years ago, you know, and then a New York Times article came out and celebrities are like, hey, what about me? I'm going through menopause. I think it's changing. And so I'm sorry that happened to you, but don't put it behind you and ask everyone you talk to now.
Thank you. Thank you. And we are taking a stand, and we can't take a stand without top professionals like you all. So thank you for this really informative presentation. I am sorry we've run out of time, but this was so incredibly helpful, and people, I don't know if you've seen the chat, but there's been great appreciation for all that you've delivered, and we really appreciate you being willing to have this crucial conversation. So I want to thank you all for coming, and thank you, Dr. Rojas. Thank you, Dr. Wood. Have a good day.
Thanks for having us. Bye.
Thank you, everyone. Have a great day.